Okay, I think we'll go ahead and get started. So welcome everyone to this Food is Medicine Massachusetts Technical Assistance webinar titled Federal Policy Update. So we all know that it has been an extremely exciting year for the food is medicine space. This past September, we celebrated the White House Conference on Hunger, Nutrition, and Health. And then there's been just a flurry of activity and interest in the connection between food and health since that time. And so we at Food is Medicine Massachusetts, our Massachusetts statewide coalition focused on advancing food is medicine, thought this would be a great moment to bring together some policy experts to think about not only reflecting back on the year behind us, but looking towards the year ahead and what sort of changes we can expect or push for over the next year. So today we're joined by three experts. So Abby Bonus, partner at NVG and leader of the Federal Policy Work Group for NPPC, or National Produce Prescription Collaborative. Alyssa Wasung, Executive Director of the Food is Medicine Coalition, or FIMMA, and Heather Latino, Clinical Instructor at the Food Law and Policy Clinic at Harvard Law School. So I'll go ahead by starting to ask each of our panelists to introduce themselves a bit more and the organization that they're representing on our call today, so you can get a better sense in our audience of their backgrounds and the missions that they represent. So give me just a moment while I pull up my slides. Are you all able to see that? Yes? Okay. So I'll go ahead and I'll let Alyssa kick us off.
Thanks so much, Katie. Hi, everybody. Thanks for joining us today. We get to talk about one of our favorite topics at FIMMA, which is federal policy and access to the life-saving interventions in the food is medicine spectrum. I'm the Executive Director of the Food is Medicine Coalition, which is a national coalition of nonprofit organizations that provide medically tailored meals and groceries, medical nutrition therapy, and nutrition counseling and education to people in communities across the country living with severe, complex, and chronic illnesses. Together, we gather to advance equitable access to these life-saving interventions through policy change, research and evaluation, and best practices, which you see here on our lovely graphic. The agencies that are part of FIMMA created the medically tailored meal model about 40 years ago, and we maintain the nutrition standards for that intervention. In our offerings, we gather together a diverse community that thrives on learning, especially the technical assistance and best practices pieces of what we do. And then we also equip new organizations to launch medically tailored meal programs where there's currently no access. A little bit about the MTM intervention. As I mentioned, it was started about 40 years ago at the height of the HIV pandemic, when we were feeding people who were then living with HIV with no hope of treatment. RDNs, registered dietitians, were really critical to the beginning of our intervention, offering nutrition science-based remedies for wasting and medication side effects. And then shortly thereafter, our agencies expanded their missions to serve people living with a whole host of different illnesses. Today, that looks like meals to community members living with cancer, with renal failure, with cardiovascular disease, with diabetes, also with HIV, and many other illnesses. It's really important for us that we are tailoring our meal intervention because many of the community members that we serve live with multiple illnesses at once, hence the medically tailored meal intervention. And the way that intervention works, before I go through our programs and initiatives, is that someone is referred from the community to our agencies, their eligibility is confirmed, and then they go through an in-depth assessment with a registered dietitian that tailors their meal plan to meet their unique medical needs. It's cooked in our kitchens from scratch and then delivered to their homes so that they can enjoy home-delivered meals and can thrive and be as healthy as they can be. We definitely want to make our meals as delicious as possible because the population that we serve tends to have issues eating or appetite loss. So we like to think of our food as medicine, but it doesn't have to taste like it. Katie, you can go to the next slide. The programs that we offer at FIMMA are the Food as Medicine Coalition Accelerator that trains new programs, as I said, to deliver the medically tailored meal intervention. For us, it's really foundational that our programs are nonprofit because there currently is no dedicated federal funding for what we do, which we'll get to later. So we're really focused on embedded nonprofits that can step up to the plate and give people the access to the nutrition that they need. Our membership offerings include technical assistance, a national symposium, all centered around best practices and supporting existing providers in the services that they deliver. Finally, forthcoming this year will be our FIMMA accreditation program that will ensure fidelity to the quality standards that we believe in that have evidenced themselves in a lot of research that we'll talk about a little bit later. And we're really excited to roll that out. On the right-hand side, you can see some of our statistics. And the final thing I'll say is that we have a couple of cross-cutting initiatives that may come up later in our program today, a health equity initiative, and then of course, policy and advocacy. Thanks, Katie.
Excellent. Thank you, Alyssa. Next, I'll have Abby provide an introduction to the National Produce Prescription Collaborative. Oh, is Abby frozen? I think Abby is frozen. So what I'm going to do is I'm going to jump ahead to Heather to introduce the Food Law and Policy Clinic and the Farm Bill Law Enterprise while Abby drops off and joins back.
Thank you so much, Katie. My name is Heather Latino, and I'm a clinical instructor and also an attorney at the Harvard Food Law and Policy Clinic. And as a teaching clinic, our primary mission is to engage law students and to train the next generation of food and law and policy leaders. We do this by working in partnership with organizations and communities to provide guidance on cutting-edge food systems issues. We also work to advance the field through research, reports, and making recommendations regarding policy developments. We focus our work across 4 primary issue areas, which you can see here on the screen. The first is sustainable and equitable food production. Second, food access and nutrition. Third, community-led food systems change. And fourth, reducing food waste. The clinic is also part of the Farm Bill Law Enterprise, which is a coalition that brings together a variety of academic and clinical programs with expertise in food, agriculture, nutrition, and the environment to provide research and recommendations on the Farm Bill that cut across traditional boundaries. In addition to the Harvard Food Law and Policy Clinic, there are clinics and programs from Duke, Drake, Pace University, Vermont Law School, the University of Maryland, and others who are also members. The collaboration offers law students throughout the country the opportunity to research food and agriculture as we work towards a farm bill that reflects a thoughtful consideration of the long-term needs of our society, including economic opportunity and stability, public health and nutrition, climate change mitigation and adaptation, public resource stewardship, and of course, racial and socioeconomic justice. It is such a pleasure to be here with all of you today.
Thank you, Heather. And it looks like I think Abby is back on now, so I'm going to back up and have Abby provide a quick introduction to NPPC. Oh, we lost her again. I think she's having internet issues. I'm so sorry. So maybe what we'll do is go ahead and jump into our first question. And when she's able to get back online, we'll have her introduce NPPC before she jumps into her first question. So as I said at the outset, it's really been close to a year at this point since the White House Conference on Hunger, Nutrition, and Health. So I'd like to start by asking our panelists to really reflect back on the last 9 months or almost a year now, and think about what changes have taken place since the conference that you're most excited about. And maybe I'll start with Alyssa.
Thanks, Katie. It's hard to believe that it's been almost a year. It's also hard to believe that it's June, anyone? But I will just say that the conference itself was such a stunning moment in history and in the history of the food as medicine movement. I think seeing CBOs alongside government officials, alongside agriculture, and so many sectors represented, not only at the conference, but leading up to the conference, gives me great hope that we will be able to kind of unite around some common solutions to the barriers and problems that we continue to face at the intersection of nutrition and health. I tend to focus on the food as medicine piece, but we also need to acknowledge that the White House conference was much broader. There was a physical activity piece. There was a climate piece that people talked a lot about and felt needed to be included. And I think that that might be something Heather addresses a little bit later, but that our food is medicine system pulls from our agriculture system, and figuring out those overlays and intersections is going to be critical to the survival of whatever we create. So I think that it was a tremendously hopeful moment. And then so many commitments came out of that conference that we're starting to see the evidence of in real time, like the Rockefeller and American Heart Association research initiative, various healthcare and community coalitions coming together to try to tease out that connection of how do we refer people out from clinical walls to the community and get them the services they need and close that loop when we get there. So I think seeing it played out in real time has been tremendously energizing. It's also a bit like drinking from a fire hose. And so I think some of us in the nonprofit world and the coalition space have also been, putting so much effort and energy into making sure that this moment doesn't pass without us really getting the policy change that needs to come to enable some of the interventions on the food as medicine spectrum. The last thing I'll say is that it's been a tremendous year to connect with other people. There have been so many gatherings of very similar folks, very different folks, which has been exciting to see other voices entering the conversation. And we as humans recognizing that this conversation that is so fundamental kind of pulls on a lot of different sectors. I think at this point, before I hand it off to Heather, there is a feeling of just needing action. And I think that's what we're talking about today. And that might echo some other folks on the call's feelings as well.
Absolutely. I think I echo all of those things. So much opportunity to really connect as a community of various stakeholders that are just so interested in the connection between food and health, and this range of interventions that we describe as food as medicine that address that connection. And I realize, just for those in the audience that may not be as familiar with the topic as food as medicine, today when we're talking about food as medicine, we're particularly talking about interventions that both include the provision of food with a nexus to the healthcare system. So these include things like medically tailored meals, medically tailored groceries, produce prescriptions, and so many more. But as Alyssa also was able to point out, all of those interventions are connected to a much wider universe and foundational food access programs that are really critical. And so I think we're able to talk about all of those things today. Especially, I think we're all better equipped to talk about all of those things today, given the opportunities to connect over the last year. And so now I want to hear from Heather, from your perspective, what has been most exciting since the White House conference?
I'd like to echo a lot of what Alyssa said with maybe a slightly different lens on it. I know that leading up to the conference last year, at least over the summer, people that I was talking with expressed concern about the short timeline and how it felt kind of rushed to prepare and solicit feedback and make recommendations, and wondering, what that might look like when the conference actually convened. And then feel very fortunate to have had the opportunity to be there. And it was a tremendous event with incredibly powerful speakers, wonderful ideas being exchanged, but kind of leaving the day wondering, so what comes from this, and what will we see? And for me, I think what has been tremendous is just starting to see like bits and pieces of that starting to take shape and fall into place, whether it's around nutrition education and seeing some of the movement that's like happening there, or efforts amongst agencies to have better coordination so that folks are connected to nutrition programs that they're qualified to receive, through part of like their engagement with Medicaid or other services. And one of the things that we're reflecting on, yesterday at a conference was how at the original convening of the White House conference that was focused on hunger and nutrition, really like the monumental policies that we reflect back on and see as really shaping the system that we have today fell into place, 2 to 3 years later. And I think what, for me, I'm most excited about is being here at this time when we are starting to build those and see them hopefully taking shape, and anticipating that like, hopefully, at some point in the future, we'll be reflecting back on this like 2 to 3 year time period after the conference and all of the changes that have taken place since then. And so that's what I'm really excited about.
Excellent. Thank you, Heather. And it looks like, I think Abby is able to join us now. Abby, can you hear us? Oh, maybe not. It sounds like her office is having internet issues. So we'll see if maybe we can just get her to call in. But in the meantime, let's go on to some questions now as we reflect on those years coming. As Heather said, with the first White House conference, in many ways, the change was seen in those 2 to 3 years following the conference. And so what I want to spend the majority of our time on today is sort of reflecting on the 2 to 3 years ahead of us and what we see as most promising or challenges that we might have to face in the future, or priorities, given the national strategy has a wide range of things that were covered, and we see energy in this space on a lot of issues. And so today we can talk a little bit about what do we see as sort of the headlines and priorities over the next 2 years or so. And I'm going to try and break this down a little bit categorically because I know there's so many things that we could cover. So I'm going to break this down into a couple of categories that have really been places of focus for us at Food is Medicine Massachusetts, and I know have been priorities at the national level as well. So we're going to go ahead and start with the question of funding. So here in Massachusetts, one of our major priorities has been to continue to expand access to sustainable funding for food as medicine services. Such funding is critical to allowing food as medicine programs to grow and meet the need in our state and really across the country. However, we know that for many years now, funding for food as medicine services has been limited, though we are seeing more energy around certain flexibilities in programs like Medicaid at this point. So we know this continues to be a core goal here in Massachusetts and that we're not alone in that. Stakeholders across the country are also setting up sustainable funding as a core goal for their food as medicine programs. So let me start with Alyssa and ask you, in the wake of the White House conference, what does the national conversation look like around funding for food as medicine interventions? Are there any key opportunities you see to improve funding or address funding gaps in the coming years?
Thanks, Katie. So I always like to begin conversations about funding, just grounding again in some of the public funding streams that we're going to be discussing because they sound a lot alike. So we at the Food as Medicine Coalition have really participated in healthcare innovation in our public insurance funding streams for over a decade at this point. And those public health insurance funding streams are Medicaid, which covers low-income people in our country, and Medicare, which is insurance coverage for older Americans and people living with disabilities. And sometimes people qualify for both. Those are called our duly eligible individuals. And then increasingly, this conversation is involving other healthcare provision systems like the VA and Indian Health Services, and increasingly employer-based insurance. So I'm going to confine my conversation to Medicaid and Medicare, where we're seeing just so much energy and change this year, especially, but it's sort of the culmination of a long pathway to get to this point. So we at FIMMA, the Medically Tailored Meal Agencies, have long participated in state-based innovation through Medicaid, which is largely governed by the states. And that's because of peer-reviewed research that demonstrates that medically tailored meals, when added to someone's care plan, actually contributes to better health outcomes and lowers their cost of care. So a lot of Medicaid plans using flexibilities at the state level, also Medicare plans, have leveraged that flexibility and started to provide medically tailored meals, medically tailored groceries, produce prescriptions over time. The problem with this is that there's still huge gaps in access to this service across the country because it's kind of piecemeal implementation. So we all acknowledge at FIMMA that we're not really going to achieve our healthcare goals of lowering costs and improving health outcomes, and from a mission perspective, happy people, unless we really integrate medically tailored meals as a benefit into this structure. So post the White House conference, we're seeing a lot of energy around that, actually, from both the administrative side and the legislative side, and then some of the field building activities that we've been engaged in. On the Medicaid side, CMS has done a lot of regulatory guidance around the utilization of existing flexibilities to implement food as medicine programs at the state level. Back in December of 22, they released guidance around health-related social needs in 1115 demonstration waivers, which is a way that a state can integrate new benefits or offerings into its Medicaid program. And they recognize, CMS seemed to recognize the need for some guidance because more and more 1115 waivers are coming to CMS with these services included. And so they talked a lot about what services are allowable, especially nutrition supports, and they outlined that nutrition counseling was permissible, medically tailored meals, meal pantries, and fruit and veggie prescriptions. There were some pieces of the regulation that were challenging, like you can only provide MTMs for 6 months, which we've been in dialogue with CMS about, but really helpful and clearer guidance around how to integrate nutrition specifically into state Medicaid programs. Similarly, there exists a way to sub in a benefit for another benefit in state Medicaid programs, and more states are asking to use this in lieu of services provision to provide food as medicine. So in January, CMS also issued more guidance around that. So the through line here is that there is a recognition of the growing need to integrate these services, and the regulatory library is growing around how to do this in a way that fits the guidance of CMS. I think there's also more movement on the research side from the research sides of government, which we'll talk about in a little bit. But NIH specifically is really focused on expanding the evidence base for food as medicine so that the decisions we make about coverage and policy are based on data. Over to the legislative side, and then I'll hand it back to you, Heather, for your thoughts. But we all know that medically tailored meals is not a benefit. We also know that we, as sort of a group of nonprofit providers, have gone as far as we can in proving that MTM really is cost effective and a necessary treatment option for people living with severe and critical illness. 2 years ago, some bipartisan champions in Congress, namely Representative McGovern and other members of the Food as Medicine Working Group, introduced a pilot act that would set up a medically tailored meal demonstration pilot in Medicare, again for older Americans and those living with disabilities, that would basically ensure that this intervention is tested in a geographically diverse way and give us the evidence to build a more effective healthcare system. There were multiple co-sponsors. It was introduced in a bipartisan way in 2020 and then again in 2021. And we're really excited to hear that we are anticipating it being introduced again, and this time on both sides in a bicameral way. So lots of movement and energy there, looking at ways to further both the evidence side of what we're looking at and the actual implementation side of what we're looking at when it comes to funding, but still no benefit.
Alyssa, one quick follow-up question before I jump to Heather or Abby. We have one question in the audience that was asking, how can we I'd probably convince policymakers to fund food as medicine in rural, mostly conservative states, especially ones that haven't expanded Medicaid? You just highlighted the important role and opportunities we have in Medicaid through things like 1115 waivers and in lieu of services. So the question here is really thinking about how do we move those types of funding opportunities forward in more rural conservative states?
Such a great question. I think for the first thing that I'll say is, surprisingly, some of the newer 1115 waivers that have been approved are not in the states that you would think: California, Pennsylvania, Massachusetts. These are Arkansas or Arizona or other states that are looking at. North Carolina has a robust and very broadly conceived healthy opportunities pilot. So it is happening much more broadly than we at first would think, looking at these waiver opportunities. So those are great things to point to, and maybe we can send some follow-up links. The other side is that food as medicine is solidly a bipartisan issue. Legislators in states across the country are grappling with hunger, they're grappling with negative health outcomes, they're grappling with rising healthcare costs. Food as medicine interventions, especially medically tailored meals, answer all three of those needs, and they do so in a way that provides care to citizens. And I think for all of these reasons, if you enter in that way, it can open up a conversation that wasn't there before. The most important point I would think too is to emphasize the cost savings. Last October, Tufts the Tufts Friedman School released a study that models what would happen if everybody who truly needs a medically tailored meal got it in our country, and what would happen to our healthcare costs and what could we expect. And they showed that in just 1 year, we would reap a net cost saving, so that's inclusive of the meals, of $13.6 billion with a B dollars. So this is not something that we can afford to ignore for the well-being of citizens and constituents, which is a great entree, or for our bottom line when it comes to healthcare. I hope that's helpful.
Thank you. I think that answers the question beautifully. Thank you, Alyssa. And now I think Abby was able to join us via phone. Abby, are you there? Can you unmute? Abby, are you on the line?
Hi, I think I'm back on. Hello.
You are. Welcome back. So, Abby, while you were trying to sort out your internet issues, we did a quick introduction from Heather and Alyssa, and we're now talking about funding. So how about I'll bring up your slides if you want to introduce NPPC, and then I'll jump right from there to my question about the funding outlook for produce prescriptions for you, sort of what you see as the national conversation around funding for produce prescriptions. But first, I'll let you introduce yourself and NPPC.
That sounds wonderful, and thank you, and apologies to everyone. Our building Wi-Fi went out. It's still not back up, so I am on phone, but I am here in spirit, and if I am able to, I will switch back onto being an online participant when I can. But thank you for having National Produce Prescription Collaborative on today. We're so excited to be here as part of this important conversation. For those of you that don't know us, the National Produce Prescription Collaborative has been around since about 2019, and our focus is to try to support produce prescriptions in the healthcare setting. Our members are practitioners and researchers, providers, we have payers and advocacy groups, and we all recognize that vital role of food and nutrition in improving health and wellness. And so our organizations have been working together to support produce prescription. Many of our members are produce prescription practitioners, so they know firsthand how these programs work, and really trying to focus on the healthcare space. On my second slide, you should be looking at the definition of produce prescriptions. because it's a term that I throw out all the time. But for those of you that aren't as familiar, MPPC has defined produce prescriptions as a medical treatment or a preventative service for patients that are usually screened in and have a diet-related health risk or condition and food insecurity, and therefore they are able to receive a prescription to obtain food at a retail setting. So that could come in the form of a voucher or a card with some financial supports, or even direct bag of produce. But really what we realize overall, and the research shows this, is that we have the ability to improve healthcare outcomes really by increasing patients' access to fruits and vegetables as part of their healthcare treatment. So I very much look forward to the conversation, what's left of it. And again, apologies for my technical issues here.
No problem at all. And I'll jump right to you then for this question. So Alyssa was just talking to us a bit about the funding opportunities for food as medicine writ large, including some of the energy we see in the Medicaid space around things like in lieu of services and managed care, and these large 1115 demonstration waivers, really emphasizing that we have some energy and opportunity for food as medicine funding, especially at the state level. I'd now like to ask you from the produce prescription perspective, what's your view on the conversation around funding for these services? Are there any key opportunities you'd like to raise up as you think about the next 2 years and funding?
Absolutely, thank you. And I probably agree with everything Alyssa said from the produce prescription perspective as well. We see those Medicaid demonstration waivers as such an important opportunity for getting produce prescriptions available in states across the country. And even since that has come out, we've just seen so much interest and excitement to move those forward. On the federal lens, however, I would also just add that we've seen a lot of great opportunities through the appropriations process, which is the annual funding process from Congress, to try to support and generate support for produce prescriptions in that healthcare setting. So over the last couple of years, Congress has actually appropriated or provided dollars, relatively small in terms of congressional money, but really important in terms of setting the stage and frameworks for produce prescriptions in other healthcare settings. So, for example, the Indian Health Service had an appropriation for $3 million that was in the last 2 appropriations bills. And just last spring, IHS had put out their request for grantees and proposals, and that process just closed in June. So we're really excited to follow that and start to see what can happen as we provide these demonstrations within an agency like Indian Health Service. And similarly with the Department of Veterans Affairs. Again, in the appropriations process, there has been an allocation of $2 million over the last 2 appropriation cycles. And we're waiting to see that get up and running, but it's, again, another great opportunity to provide produce prescriptions and this benefit to our veterans across the country. And the final one I would just note, also in this appropriation space, was a nod to the Department of Health and Human Services last year. There was a $2 million allocation there. And some of that work we believe is actually going to go into kind of more of a landscape report, but it's an opportunity to look at produce prescription and food as medicine more generally. So the work of the, food as medicine comes in different forms. And I think, they all are very much companions and go hand in hand together. So as we can be learning more about all of them together, that will be a great opportunity for us. I say these updates from last year's appropriations because this year's appropriations is happening, but very slowly and not without some challenges in Congress right now. But at some point over the next couple of weeks and months, they will take up all these bills individually and start to see if there's additional opportunities for these types of programs to continue to grow through that lens. So we see, again, a really important opportunity to try to generate funding and funding support. I would also note from our MPPC lens, one of our additional appropriations asks is around research. And so that may be something I know will come up later in this conversation, but I also wanted to note that as an additional part of what we see as a good funding opportunity.
Excellent. Thank you, Abby. And now I'd like to turn to Heather, which is a great segue since we're talking a little bit about the federal legislative process. We know that we're in a key year in terms of nutrition legislation because we are in a Farm Bill year. The Farm Bill being the legislation that determines the scope and funding for many nutrition programs in the United States and many of our really foundational food access programs like SNAP. So Heather, I know that many of these programs are likely of interest to our audience. So what are you and your colleagues across the Farm Bill law enterprise focusing on and thinking about as we approach the next Farm Bill?
Thank you so much, Katie. And I'm going to apologize in advance because I feel like we could take the entire hour or even an entire semester to talk about the Farm Bill because there's really a lot to unpack. And so in addition to the two things that Katie mentioned, that funding mechanism for nutrition programs that really enhance population level health, and also a funding mechanism for some of the programs that directly support food as medicine, like the GusNIP Nutrition Incentive Program that provides funding for produce prescription programs. The other way that the Farm Bill really impacts food as medicine is it's the mechanism by which we really as a country prioritize what types of food are available, how they're produced, and where that food comes from, which impacts the type of food that feeds into our food as medicine system. And so it's really important, and these conversations are critical. I think it might be helpful just to step back a bit and provide a bit of context about what the Farm Bill is and how it operates. It's an omnibus bill, which means that it brings together and packages multiple appropriation bills into one big package. I've heard people reference 8,000 pages of text. I don't know if that's the right number, but just imagine this is huge. And it governs many of our agriculture and food programs. And because it's a multi-year law that operates in 5-year cycles, it will have a significant impact on the way that these programs look for the near to midterm future. Because it's on that 5-year cycle, it also means that timing is really important because we are at this time period where the last 5-year cycle is about to expire in September at the end of the fiscal year. And without reauthorization, some programs that are funded by the bill, like nutrition assistance programs, farm commodities, could potentially expire unless the Farm Bill is extended. And so timing is something that's very much on everyone's mind. Because if it expires and is not extended, the consequences can range from minimal disruption if programs continue via appropriations to some disruption where programs might have to cease new activity if authorization to use mandatory funding expires, which is something that happened trying to remember the year, but I think it was back in 2012, that was something that was experienced then, to the most significant impact, which would be reverting back to the way that the laws existed in the late 1930s and early 1940s, which the positive of that is that that's really not an outcome that anyone wants. It would be expensive. It's not aligned with the way that our food system works. And because of that, I think that that's extremely unlikely to see. The other thing that I think is really interesting about the Farm Bill is because you have tied together agriculture programs with nutrition programs, it's one of these places where stakeholders with really divergent and sometimes conflicting interests come together to really try to make things happen because they have a shared desire to have that bill passed in the end. And so sometimes that can be an effective way to move things forward. So I'm going to pause, and we talked a little bit about what's in it, that it includes agriculture programs, which can include things like crop insurance and conservation programs, that it includes on the other side nutrition programs, things like SNAP or the Emergency Food Assistance Program, nutrition incentive programs, But I also want to note that it doesn't fund all of our nutrition programs in the United States. There are programs that are funded through other reauthorization bills. So a good example of that is WIC, or the school meals program. And so those are not things that are being discussed as part of this Farm Bill cycle. And as we think about the way that the Farm Bill breaks down, one of the reasons that so much of the discourse and the conversation is focused on nutrition programs is because they're projected in this cycle to account for approximately 80% of the Farm Bill baseline. And when we talk about a baseline, that's kind of the budget that is set during the process that governs how much can be spent going forward indefinitely and taking into account inflation. But it creates this concept that if you're going to bring in things that need additional funding, you need to figure out where to pull that funding from in other places. And that can be a challenge. And because so much of it is associated with nutrition programs, it really ends up focusing a lot of the debate around nutrition programs, which is unfortunate because I think a lot of us in this space wish that there were more discussions about ways to really disrupt the way that we are funding our agriculture system to better reflect some of the values that we currently hold around sustainability and the environment and climate change. So kind of stepping back to and focusing on this question of timing, one of the unfortunate things that I think we've seen play out this spring is one, that there's been more delay, I think, in the hearing process than folks would like, and hope to see more activity happening with hearings early on. But that was coupled with really contentious debates around the debt ceiling, which I also think delayed the timing of the Farm Bill as well. And that's unfortunate because ag and nutrition programs make up less than 2% of the total federal spending budget. And so I think there is really a disproportionate emphasis on how those programs were funded. One of the things that kind of came out of the debt ceiling conversations is that, there were some funds that were unobligated from ARPA or from the CARES Act that were rescinded. And part of the hope was that those funds could have been reinvested into discretionary funding for the Farm Bill, which it doesn't look like is a possibility at this point. And so it seems that it's going to be harder to move forward programs that require new funding. But hopefully that's not the case. And that is certainly yet to be seen. And so where we're at in the process is that the House and the Senate Agriculture Committees both need to draft their farm bills, respective farm bills. And it's my understanding that the Senate has started putting pen to paper and that process is underway, and that that's supposed to have been happening in the House in late June. And so perhaps that's also happening now as we speak. Once that's done, those bills go to debate and try to pass out of the committee. And hopefully that will be happening in September is kind of what's anticipated in terms of a time frame for that. Once they're passed out of committee, they still need to go to the full House or Senate for debate. They can be sent back to the committees for additional work. When they're ready, they go to the full Congress for a vote on the floor and then to the White House to either pass or veto those bills. And so we still have a lot to get done as part of the process. The inside scoop is that people are hopeful that we'll be done with that by year end, but also think that that's probably an ambitious timeline. And certainly we've seen the Farm Bill extended in the past for multiple months, multiple years. And so I think what we can anticipate is that in the fall, there are going to be discussions and extensions of the Farm Bill to accommodate this process going forward, would be my expectation. The recent hearing that was held on the Farm Bill happened on June 7th, and I think it was really a good opportunity to see what the battle lines or battleground will be around nutrition programs in the Farm Bill. And as you can imagine, and is probably not a surprise to folks on this call, on one hand, you have the Republicans who are, making clear that they don't see the concessions that were made around SNAP as taking off further conversations and restrictions about SNAP moving forward, and that they very much see that as part of the ongoing debate. And so a lot of discourse around how nutrition programs should be a hand up and not a handout, in reference to potentially adding, or like additional work requirements, a very unfortunate focus on program integrity and funding, like program integrity to watch for fraud in the system, and a lot of discussions about concern that the program subsidize, like SNAP in particular, the purchase of unhealthy food. And then on the flip side, you have the Democrats, being very clear and saying, let me be very clear, I will not support any further cuts or restrictions to SNAP, and really calling for different ways that the program can be strengthened. And so I think that those contentious debates are something that we're going to continue to see happening. And as they're happening with regard to SNAP, we're seeing what I think are some really positive developments related to nutrition incentive programs that relate to food as medicine, where I think that, as Alyssa mentioned, there's more of an opportunity for bipartisan support in both parties to come together around shared value of making sure that people have access to nutritious foods. And so a couple of the marker bills that I just want to raise up, make sure that they're on folks' radars, is there was one introduced early in the spring called the Local Farms and Food Act of 2023. It was introduced on the House side by Representative Pingree with Republican support, and on the Senate side was introduced by Senator Sherrod Brown. That bill proposes to do three things. First, it proposes to reduce the GUSNIP, which is the Gus Schumacher Nutrition Incentive Program, the matching requirement for nutrition incentives from the 50% match to the 25% match. Second, it proposes to reauthorize the Senior Farmers Market Nutrition Program, which again is a nutrition incentive program that's specifically geared to seniors to help them purchase locally grown fruits and vegetables. And third, to establish a separate review panel for produce prescription grants, so that the review panel would include healthcare providers in that review process. And so that's one of the marker bills that's being considered. Another one dropped last week. It was introduced as a bicameral bill as well, by Senator Booker and Representative Blunt. It's cleverly entitled the O-SNAP Act, which is short for Opt for Health with SNAP, Close the Fruit and Vegetable Gap Act. And what that bill proposes to do is to increase the current level of funding, which is $250 million over a 5-year period, to a funding level of $3.5 billion over that same time period. So, kind of a blue sky approach to funding the Gus Schumacher Nutrition Incentive Program, a portion of which, of course, would go to funding produce prescription programs if it passes. And so I think that that's something, to be optimistic that we're talking about and discussing. It was co-sponsored by Senator Markey from Massachusetts as well. And then there's some rumor, and perhaps Abby can clarify whether this might actually be coming to fruition, but it sounds like there's some chatter that there might also be a reform bill coming down the pipeline that would propose 2 different tiers of grants for produce prescription grants in particular. One that, I think perhaps trying to forecast what this might look like would be to provide funding to scale food as medicine projects, and then separately grants that would seed infrastructure projects and would be funded at a lower level. But there's some discussion about that potentially being in the works, and that Representative Kildee from Washington, Crawford from Arkansas, and Senator Hirano from Hawaii, might be talking about what that could look like. And so some important conversations really happening around the Farm Bill. which I think is a reason to be optimistic that maybe we'll see perhaps some increased funding levels that would help to support these programs going forward.
Thank you so much, Heather. That's a great overview, and I think a nice segue into sort of our next topic, which is thinking about research opportunities. I know Abby touched on this briefly in thinking about appropriations around NIH. We know that GusNIP, of course, also one of the goals there is to advance sort of our understanding of the impact of programs like produce prescriptions. And so I'm going to ask each of you to just comment on first, what opportunities you see coming up at the national level to advance research on food as medicine over the next year. And I'll combine this with a second question, which what research questions do you hope that research will answer? So what opportunities do you see, and what do you see as the research priorities for those projects? I'll start with Alyssa.
Thanks, Katie. And thank you so much, Heather, for that overview. So much to dig into. And again, I just want to highlight the connection between the provision of food as medicine and where our food comes from. So I think from my perspective, as I mentioned in the last section where we were talking about funding, the field right now has a lot of focus on research and research funding, and evaluation from our perspective at FIMMA really should be part of each and every time we are providing these services to folks. We should be, number one, looking at the quality of the service provided, but also at the outcome. So we're steadily building that evidence base. So when we get to that policy moment, no one can poke holes in the argument, as it were. And so we definitely encourage our partner agencies to do that with their healthcare plan partners whenever they are embarking on new innovations. But I think on a broader scale, the question really is there enough research? And I think as part of the work that some of the folks on this call and a much broader coalition did with the Food as Medicine Research Action Plan, the answer is there is a lot and we can always do more. And so from my perspective, I think the opportunities are really broad this year. I mentioned the American Heart Association and Rockefeller focus on a very ambitious and multi-year research initiative that is taking shape as we speak. And then there is movement also from the administration. NIH released a request for information about food as medicine research and what the community, what the country would like to see as it targets implementing its centers of excellence concept that was approved, but does need to be funded. So we still need to do some advocacy there. So NIH has really taken an interest in the nutrition science piece of food as medicine research, and looking forward to seeing how that plays out. From our perspective, the Demonstration Pilot Act is also a research study. It is a way to look at mechanisms, which is equally important. We're not just looking at outcomes, but how do people get connected to the service in various populations and different geographies? It allows us to sort of test the MTM intervention and see how it functions in different landscapes. And then finally, I would say in terms of focus, there is an increasing interest in how we do the research that we're doing. A key outcome of the Aspen Institute's Food as Medicine Research Action Plan was a really deep paying attention to equity in research. The fact that food isn't necessarily able to be researched like other medical interventions, and an attention to involving the subjects of our research and the design of the research. And as we design research studies that include populations that face added burdens in accessing services for nutrition, but all services, it's so important to involve the CBOs, the community-based organizations and nonprofits that serve those populations and those communities, as well as the communities in the design of the research, so that we're not reinventing wheels that don't work. So I think that that focus on client need, client perspective, we call patients clients, community input, co-designed research is such a positive trend. And I believe that it will result in better information as we roll out interventions. What am I excited about in terms of outcomes? Of course, I could throw out the triple aim, the quadruple aim again. But I think for me, it is, the unintended outcomes of food, like when we are feeding a whole family, like look at the effect of food provision on a caregiving structure, which is largely invisible in our country today. Can we tease that out and understand what the benefits of that are in the near term, in the long term? Looking at more qualitative outcomes, such as quality of life and patient satisfaction and sort of the more human outcomes of food provision. Those are some of the things that really excite me. And I think, solidifying some of the research outcomes that we already know. Thanks, Katie.
Thanks, Alyssa. And now I'd like to turn to Abby to see if you have thoughts on this, on research opportunities over the next year and any particular priorities NPPC is focused on.
Thank you. I think that was fantastic because I think it covered so many of the ones that I was going to also, get behind. I think one of the reasons we're pushing so hard to support the idea of these demos, especially in the closed health systems like Indian Health Service and the Department of Veterans Affairs, is we see this as an opportunity to kind of go deep in terms of the data and start to look at those health impacts directly. And I think that from our perspective, working to try to think about produce prescriptions in health, it is some of that healthcare data that we're interested in learning more and tracking more. We've had so many great examples of produce prescriptions over the last decade, but I think what we're really looking forward to is trying to figure out how to get some of that longer term longitudinal following people that have done these programs. And that does take time, but that is what we're striving for. I think very much so in terms of as we're looking to do the research. And that's one of the reasons we're also so excited about some of the partnerships that Rockefeller has going on in the VA right now too, because I think they're starting to think about of those data points. So just to say a lot of exciting stuff at the brink there, but more that we can be supporting. NIH Office of Nutrition Research, the budget had a really nice number there, but it's going to be very hard work to bring those dollars forward. So definitely looking forward to kind of just supporting the ability to do this work moving forward as well. So I think that's those are the only things I would add into the conversation. But I think just to overall, we see the data as kind of the key to being able to expand this work moving forward, especially when it comes to Congress, creating programs or authorizing more of this work. They're going to want to see the results in the data. And so the more we have, the more we can just make the case to grow produce prescription and food as medicine work overall.
Excellent. Thank you, Abby. And I know, Abby, you may have to drop off, which is totally fine. But I think we'll continue with Alyssa and Heather here. So Heather, from your perspective, same question. What are we looking at in terms of research? And are there any particular priorities that you and your colleagues have been talking about as we think about what we want to come out of that research?
I am similar to Abby, really appreciate Alyssa's comments, especially as related to equity and serving populations that may not have had as much access to these programs in the past as we would like. Just in thinking about GusNIP, the Gus Schumacher Nutrition Incentive Program and produce prescription grants, that program is really all about research. Its purpose is to demonstrate and evaluate the impact of projects on dietary health, food insecurity, healthcare use and costs. And one of the things that happened earlier this year was that the GusNIP Training Technical Assistance Evaluation and Information Center announced a new funding opportunity, albeit I don't think it's sufficient, but $25,000 that's aimed at building the capacity of organizations that had not ever applied for or been awarded GusNIP grants in the past. And they specifically were encouraging applications from tribal communities, U.S. territories, and states that have yet to receive funding for the program. And I think that that's a really promising start to expanding the geographic reach and the equity of the program, and potentially some of the research that can happen around how these nutrition programs can support Black, Latinx, Indigenous, or other marginalized communities. And really appreciate Alyssa talking about the importance of involving those communities and shaping what that research looks like. But I think that that's a really important priority that hopefully we'll see further research on in the coming years.
That's fantastic. And thank you for lifting up that piece around capacity building. I think that's so critical and actually leads a little bit into the next topic I'd like to focus on, which is infrastructure. The fact that we, in order to really establish equitable access to food as medicine services, we need to build the infrastructure across the country to make sure that they can reach everyone who needs them. And so part of that is capacity building, but there's a number of other topics that sort of fall in this category of infrastructure. So as we here in Massachusetts think about food as medicine services, we know that it's really a multi-step process, right? It requires the coordination of many individuals, organizations, and systems. And so infrastructure is such a critical piece of the puzzle for expanding access. And we've seen really difficult and important work happening to establish the systems needed to effectively move patients from initial screening to referral to having access to services so that they can receive them. And then also concurrent and equally important work to set up systems that food as medicine programs need on the back end to communicate with healthcare partners, to bill for services, and to evaluate impact. So we really think about all of that as establishing the backbone that we need to get these valuable interventions into the hands of people who need them, and to make sure that the organizations who are providing them have the support they need to effectively be able to sort of bill and be supported in their work. So as you all step back and look at the national landscape, what progress are you seeing in setting up that type of food as medicine infrastructure? And what are your thoughts on priorities for infrastructure in the year ahead? So maybe I'll start with Heather this time.
Thanks so much, Katie. I'll take advantage of the opportunity to focus kind of early on in the process and thinking about like referrals, and what happens like during those interactions with a primary care physician. So one of the issues and concerns that the clinic has had for a long time is centered around nutrition education for physicians. And I'm going to try to channel our director, Emily Broad-Lieb, who I know has a really deep interest in this area and authored a report in 2019 called Doctoring Our Diets, which really highlighted some of the deficiencies in nutrition education that currently exist, highlighting that less than 1% of all lecture hours during undergraduate medical education are devoted to nutrition education. At the graduate level, requirements for nutrition curriculums and competencies are limited or absent. And that at the continuing medical education level, so like once physicians have graduated and are practicing, no state is requiring that doctors take nutrition or diet education as part of those continuing medical education requirements, although many require it for other subjects. And so there's been, I think I alluded to this earlier, there's been, I think like some really great activity in this area over the course of the past year, starting with the bill that Representative McGovern really championed around this issue, which passed the House as a bipartisan bill. And it did four things. It urged medical institutions to incorporate nutrition education into their curriculum, encourage some research into developing effective education programs for physicians, supported disseminating best practices to medical programs and then also raising awareness of how nutrition impacts patient health outcomes. And then, that initial momentum was, of course, built on at the White House conference, which included calls for increasing nutrition education for physicians in its recommendations. And then this spring, there was the first ever summit on medical education focused on nutrition that was convened by the Accreditation Council for Graduate Medical Education, ACGME, the American Association of Colleges of Osteopathic Medicine, as well as the Association of American Medical Colleges. And what they did was they brought together more than 150 medical education professionals to talk about whether, and to some degree how, nutrition education should be increased during graduate medical education programs. So when folks are going through their residency or doing their fellowship, as well as in medical education more broadly. The findings from that summit and those working groups have not yet been published, and we're hopeful that they'll incorporate nutrition education into residency training in some form, even though we're not certain what that will look like. But really think that we're seeing the momentum shift and a sea change. And in the coming year, Katie, what we think some of the top and key priorities should and could be would be really pushing the federal government to be a leader in this space. It's one of the largest employers of physicians, and it could require continuing medical education requirements for any doctor that's employed by the federal government, and that would really shift the landscape as well. Medicare is one of the largest sources of federal funding for residency programs, and the federal government could condition that funding on requiring nutrition education. And so I think what we're hopeful to see in the coming year is perhaps for the federal government to take a leadership role in this space, but also to see some of the work that perhaps comes out of the discussions that have been happening.
Excellent. Thank you, Heather. And we know that nutrition education for our healthcare providers is so critical, especially as we're seeing more and more policies placing healthcare providers in many ways as gatekeepers to these important interventions, really relying on them to be able to identify the patients who could benefit most from many of the interventions we're talking about here today, and making sure they're connected. So I think that is a really critical piece of the puzzle. And now, Alyssa, I'd like to turn to you and ask the same question. What is FIMMA thinking about in terms of infrastructure, and what are your priorities?
Thanks, Katie, and thanks, Heather. I just so echo the nutrition education for MDs, but I would expand it even more broadly. The doctors in our country, think post-COVID, during COVID, largely PCPs, which there's a shortage of in our country, are already burdened with not enough time to even talk to their patients. So we really need to think practically about who could and can address the nutrition needs in an office. A great example is the Medical Nutrition Therapy Act that expands the ability to identify a need for medical nutrition therapy, which is an evidence-based care process enacted by an RDN with somebody, to NPs, PAs, other medical professionals that can assist and prescribe that intervention. So I think it's a really holistic view of how we set up systems that don't overburden certain pieces of the system and don't inadvertently kind of throw up barriers for patients that are trying to access these services. I think one of the things that also came out of the White House conference was you heard the witness of a lot of providers who know that there's need in their communities. They know that there is food insecurity, they know there's housing insecurity, legal issues. Once you pull on one, I think health-related social need, it often comes with other needs. And so creating a system that can adequately address and assess, and then more importantly, refer to reliable services is really what is before us as a nation. Up until now, I think these systems have been disconnected, and especially as we've endeavored to integrate nutrition into medical care, there's been such piecemeal implementation that it has already resulted in multiple systems. And because nonprofits tend to be on the receiving end of referrals, the capacity burden has rested on community-based organizations, has rested on nonprofits to be in all of those systems if they want to participate in what is going on in healthcare. So I think a little ex post facto, we're recognizing that, oh, we need to create a more common system of understanding of how we screen someone, what a screening means, which is a big definitional issue right now, and how we reliably refer to services that are then reimbursed. And that is kind of the through line that we are working on at this moment in integration. FIMMA agencies have our roots in HIV, therefore are quite versed in confidentiality, in HIPAA, and in participating in healthcare, which is why I think we have kind of that forefront position of having done some of these things as community-based providers, and we do our best to share that knowledge in our state-based environment and beyond. I think in terms of progress, we're seeing a lot of focus on regulatory language around encouraging screening. Again, we love that, but also need to think about the referral piece of it. Really not, it's a justice issue if we're screening for something and we find a positive screen and then have nowhere to send that person. And I think we heard that from our provider community. So really have to think about the whole system, but great progress on screening. And attention paid to data and systems and the barriers there with HIPAA, with protected health information, making sure we honor a client's choice to share or not share information, and how do we facilitate those exchanges. And then I think we saw post-White House conference and a bit before an interest in a broader base of coalitions that are from the healthcare side, working in partnership to try to figure this out with community. Coalitions like the Partnership to Align Social Care or Sync for Social Needs are trying to figure it out from the healthcare side because they recognize the need to train and equip their staff to do it right. So I think that there's a lot of energy there. For us at FIMMA, priorities for the coming year are some of those federal, as Heather mentions, that federal involvement in answering some of these questions about regulations and privacy and data, about how to best identify and refer. For us at FIMMA, more specifically, we have a real focus on health equity, and in creating this system, how do we not inadvertently create barriers because we're over screening or burdening clients, or what does it mean to measure health equity in a system? What are those reliable measurements? We also recognize that we don't actually have the language to describe these interventions in someone's health record, so we're not accurately telling a patient's story yet. And so with the Coding for Food project, which we can provide some information on, we're trying to develop those codes, those billing codes, those referral result codes that will be the through line for somebody to actually get the intervention they need. And then I think finally, the accreditation program that we're putting forth really focuses on quality and how to know what the definition of an intervention is, so it's recognizable when we see it. Thanks, Katie.
So many important points there. And I think so many that we're seeing policy create some pressure for action on, right? I think in a number of the states that have some large scale food as medicine demonstrations in their Medicaid program, we are seeing a shift to this idea of, can we make the way we approach food as medicine services look more and more like the way we would approach traditional medical care. So I think we've seen in that conversation this idea of, let's push towards having standardized billing codes, right? And so I think we're seeing some energy and some pressure from the policy side that hopefully will move us towards building some of those answers at the national level around infrastructure that we really need to effectively integrate these interventions in a large scale way. So thank you so much for raising those points up. One other point I think that wasn't touched on that I think has been so critical here in Massachusetts and harkens back to our earlier conversation around the 1115 waivers is I think we've been really encouraged around the way that the recognition of the importance of infrastructure has been built into some of our payment approaches. Under our previous waiver here in Massachusetts, We had our social service organization prep fund that was so critical to allowing many community-based organizations to set up the infrastructure they needed, the technology, the staffing they needed to be able to partner with healthcare. And we know that that is now continuing in our next waiver as the Social Service Integration Fund, and in fact has been really raised up and built into CMS's approach in that 1115 waiver framework that was put out this past December. So I found that incredibly encouraging that it's not just the CBOs on the ground that recognize this need, but some real recognition from state and federal policymakers that, again, to make this work, we need to be providing some support to build the structures needed for effective partnership. And Alyssa, I see you've got your hand raised.
Yeah, Katie, I think you just bring up a great grounding in state environments. And I also wanted to lift up what I saw as a Q&A about the role of RDNs. And I'd like to almost expand that a little bit because those two are the two comments are related, but registered dietitians are nutrition science professionals. And part of this integration is raising them up and really examining diversity in dietetics and encouraging them to be part of an interdisciplinary team. They know nutrition, it is their job, right? And so I think really thinking through critically how we involve them more in people's care as part of it. The same thing goes for social workers, right? We have talked a lot about screening. We've talked a lot about public health. Social workers are trained to identify and to help people navigate these systems. So some of this is also capacity in other areas of our healthcare system that we really need to consider as we start to integrate these systems more effectively.
Excellent, thank you. And I know we're coming up on our last 10 minutes, so I want to make sure that we have time for our sort of final lightning round, which is that I asked each of our panelists to essentially say, if you had a couple of points that you'd like attendees to take away from the session today, what would they be? Calls to action, key priorities from your organizations, what should they be thinking about or acting on in the year ahead? And so I'm going to go ahead and pull our slides back up. And so first, I'll just give a quick overview of NPPC's stated policy priorities, many of which Abby covered earlier today. So this is in many ways just a review of where they're headed. First, we heard a lot about Medicaid today, and we've started to see the federal government issuing guidance around health-related social needs and the avenues for doing so. So here you see a priority of continuing to issue guidance to states on using produce prescriptions specifically in their Medicaid programs. Then in Medicare, really a priority to advance utilization of produce prescriptions under some of the flexibilities in Medicare that allow payment, like special supplemental benefits for the chronically ill, and to share data to break down silos in Medicare Advantage and provide produce prescription benefit within Medicare to cover produce and services for qualified beneficiaries. Next, we already heard a bit about the VA and the Veterans Health Administration. Abby spoke earlier to the importance of appropriations here. So one of their priorities is to utilize congressional appropriation and philanthropic support to advance a produce prescription demonstration project and establish standards for utilization of produce prescriptions within the VHA. We also discussed the Indian Health Service, again, utilizing congressional appropriation and philanthropic support to advance a produce prescription project and establish standards for utilization in IHS. One piece that hasn't come up as much, but I think is an important part of the conversation, is also quality metrics. We're seeing some really important pushes at the federal level around the use of quality metrics to incentivize or require screening and referral for health-related social needs. And so we have a priority here around advancing drivers of health screening in all government-sponsored health plans using standard measures. Of course, we also talked about funding federal research. So here you see support the National Institutes of Health Office of Nutrition Research to examine the clinical impact of produce prescriptions. That would be connected with some of the concepts we discussed earlier, like the Centers of Excellence. And then, of course, the United States Department of Agriculture, really continuing to invest in produce prescription programs and infrastructure through the GusNIP program that Heather talked about earlier, and support the development and clinical validation of nutrition insecurity measure for use in the healthcare practice. And next, I'm going to jump to FIMMA. So Alyssa, if you can tell me, what are your key takeaways for our audience?
Thanks, Katie. And I'll go quickly because I want to get to your questions. You can just click all the way through, Katie, so that we can save time. I think on the left-hand side, I just want to remind everybody of the tremendous research base that MTM stands on. And I want to acknowledge Community Servings as a real research leader in that space. The JAMA study is summarized right there. And then for public policy, I think one of our key asks, especially for this Congress, is when it's introduced, you'll see that number 1, support the MTM pilot bill, because getting it passed and inculcated during this Congress is tremendously important so we can start to advance the field. I really was thinking of it from your perspective. You know, we have our own priorities, which Jean just posted in the chat. They mirror these, but thinking about all the many ways that you could influence state innovation through the flexibilities that CMS has been very vocal about allowing, and the increasing research base to convince your state policymakers. We endeavor to provide a community of learning around that. So does NPPC. So we are here to help think these things through. And then finally, administrative opportunities. Katie just mentioned regulations. I know that they can be a bit of a yawn, but they matter so much. If we're going to screen folks and we need to refer folks, what are these quality incentives that hospitals, providers, and payers are being asked to leverage in their setting up of their systems? So paying attention to some of those administrative opportunities. The NIH RFI is due June 30. Please respond if you have thoughts about how to further food as medicine research. And for further information or to sign up for our listserv or to join our free quarterly meetings, please go to fimcoalition.org, and we hope to see you there.
And Heather, what are your key takeaways?
Great, thanks so much, Katie. So on the Farm Bill, my key request or call for action would be that those of you on the call take the opportunity to endorse and garner support for the acts that I mentioned earlier on, and I'll get those links dropped in the chat so that you have the connection to the language of both of those. So both the OSNAP Act and the Local Farms and Food Act of 2023, both like making sure that the folks who are pushing those marker bills forward, where they're signaling what are important policy ideas, know that they have your support, but also reaching out to those who are not sponsors or co-sponsors and getting them to provide their support as well. And earlier today, I was reading a piece about the importance of stories. And as organizations on the ground, like I have access to data, but I don't have access to stories. And stories are really what stick with people long-term in terms of advocacy. So making sure that you use the stories that you have about the work that you're doing and the impact it has to be able to promote these bills, both in terms of food as medicine, but also in terms of all of the nutrition bills that are going through both the House and the Senate related to the Farm Bill as related to programs like SNAP. And then on the nutrition education side, I really appreciate Alyssa and Katie kind of coming back to this point, which is that nutrition education is important because we want physicians to be able to refer and connect people to the appropriate resources. And it needs to happen not just for physicians, but at all levels. But just want to flag an opportunity to provide input specific to what types of competencies should be seen in the medical education for medical students. And if you have input, to take advantage of providing that. So those are the couple action items I hope to leave folks with today.
Thank you so much. And I know we have just a moment or two left here. We do have just 1 or 2 questions in the chat. So we'll see if we can get through at least 1 or 2 of them. So first, we had a question that Alyssa, I think you gestured to earlier in the Q&A, saying, thank you so much. MTM utilizes medical nutrition therapy and RDNs for state Medicaid programs that do not recognize RDNs as providers. How are they meeting the MTM requirements?
So this is a bit complicated. I'll start with the fact that we totally acknowledge and hear about RDNs not being recognized, and that's kind of part of our platform is their central role in MTM, of course, but also in nutrition care and healthcare. So medically tailored meals, the way we deliver it, does involve an RDN, but from the perspective of Medicaid, they are more focused on the meal. So right now, this is part of the whole, we don't have the language to describe what we are actually doing in healthcare. Right now, a medically tailored meal in the data and the forms and the billing codes is just a home delivered meal. And we've been working on changing that for years because it actually doesn't describe what we do. It doesn't describe the involvement of the RDN. It doesn't describe the medical tailoring and the nutrition counseling and follow-ups. That's part of creating that language for provision. That being said, right now, it allows, there are differing regulations across multiple states about RDNs, about licensure. We really partner and nod toward the Academy of Nutrition and Dietetics when it comes to RDNs and their certification. And that's kind of where we rest because state policy is so variable. So not necessarily the clear answer that I'm sure you wanted, but the ultimate answer is it actually doesn't affect the provision of services. In the future, when we have the language and RDNs are recognized as part of the clinical care continuum across the country, I think that's when this will become an issue. So good and bad.
Thanks, Elizabeth. And then we have a point that I just wanted to raise up from the chat with respect to the conversation around nutrition education. Jean Tips from the American College of Lifestyle Medicine notes that the education that they're offering is multidisciplinary for non-physicians as well. As we talked about earlier, the importance of the entire healthcare team. And they made a commitment at the White House conference to offer $22 million in pre-CME/CE. And so far, more than 23,000 have registered, which is great. I would say, a win on the front of nutrition education for our healthcare team. So thank you for sharing that, Jean. And then we have one more question that I think would be a good one to end on as we close out here, because it probably speaks to many of our audience members. So Stacy writes, being an RDN student in my master's/internship program, how can I help with these issues? Also regarding my career, what can I do to help impact change moving forward? So what can individuals interested in this space do to move all of these things forward in their home landscapes?
I'll take a first pass at that, Heather, and then feel free to jump in. So I so appreciate that question. And I think the first piece is just showing up here and absorbing and learning, which you've already done and are doing, joining into the coalitions that are working on these policy issues and the nutrition education piece to keep up to date and make sure you can engage when the moment comes. I think encouraging folks to enter the field too, much like social workers, much like PCPs, there is a shortage of RDNs in our country. So we need more nutrition professionals. We need more people paying attention, and we need diverse people paying attention to this so that we can honor people's cultural preferences and understand more about our clients. And then I'd say responding to advocacy calls and educating those around you is really an important piece. The more that people understand what food is medicine is, what a medically tailored meal, a produce prescription, a medically tailored grocery bag is, the better off we'll be when those policy opportunities present themselves. So thank you for that question.
And Heather, you get the final word here, and then we'll close out.
I think Alyssa covered it so well that there's nothing that I need to add to it. She hit every single point on that to be hit. And then thank you, Stacy, for raising the question.
Well, perfect. And thank you all so much for joining us. This was a really fantastic conversation, and we appreciate not only you taking the time to join this conversation with us today, but all of the work that all of your organizations are doing on the ground to advance the idea of food as medicine, both the local, state, and federal level. So thank you again. And I know we've had some questions about recordings and slides, so we will be sharing a recording. So keep an eye out in the next few days for that for everyone attending. And thank you so much.
Thank you, Katie, Liz, and Jean.
Thanks, everyone.
Bye, Heather.
Bye-bye.